Hello and welcome to our February Lunch and Learn titled Competing Priorities, Hospitals, Health Systems, and Health Departments. A little bit of background, our Lunch and Learns occur monthly throughout the academic year, and they are meant to allow interested students, staff, and faculty the opportunity to learn from a member of the community who may be involved in work that is relevant to interprofessionalism and team-based care. Today's speaker, Dr. Julie Bolson, is a graduate of Grand Valley State University's Bachelor of Nursing, Master of Public Administration, and Doctor of Nursing practice programs. Has worked at Spectrum in various capacities over the past 40 plus years. She's currently responsible for the emergency preparedness programs for Spectrum Health Hospital Group, as well as assisting in the development of a disaster planning program at the Spectrum Health Medical Group. Today's talk will focus on the ways in which the priorities of the various organizations focusing on improving the health of our communities align and where they may compete. So with that, I would like to turn it over to Dr. Bolson.
Thanks, Brian. So I would like to share some information with you all about something that's been very upfront in my life over the last several months. And I'm sure as most of you have been also involved in some sort of a response around the COVID-19 pandemic. And I want to talk a little bit about how through working through the hospitals and through healthcare systems and with the health department, how there might be some competing priorities among those three areas of response, but then also by the end of the conversation, I want to talk about, while there might be some competing priorities individually, as we come together collectively, certainly building a stronger response through collaboration and how that's been able to positively affect the current COVID pandemic. So I'm hoping that everyone can see my slides here. And I'm hoping that they will. There we go. So just to kind of give a little bit of a background from a pandemic planning perspective, certainly as I was thinking back and in a moment of time that I had throughout this pandemic response, thinking about the various kinds of bacterial responses that we focused on, some of the viral responses that we focused on, whether those were endemics or pandemics or whatever the case might be. I was pulling some data together for an article that is being published around the frequency of the pandemic responses and really how organizations have had to focus on this response over the last several years. And so as I looked back on that, just about every 5 years or so, right around there, there's something new that's coming into the focus of healthcare preparedness folks. And so as you look back at the slide here over the past 20 years, some of the disease-specific pandemic planning that's been a primary focus has been SARS way back in 2002. If I'm hoping that there's some folks on the phone that remember that one. H1N1 was the swine flu that they talked about back in 2009 to 2010, and that was actually our first, from a healthcare perspective in West Michigan anyway, our first exposure to pandemic planning. And there were several of the planning partners within a 13 county region that were involved in a CDC grant specifically around pandemic planning and what does it look like when you look at scarce resources and essential services that you might need to continue through a pandemic, and how does that look in the big scheme of that pandemic plan, not only from a healthcare perspective, but also from EMS and first responders and the health departments as well. So that was really our first introduction to that pandemic sort of planning and a response actually that lasted about 6 weeks. So when we were entering into COVID-19, it was like, okay, so is this going to look like H1N1? What is this going to be? I don't know that any of us anticipated that 14 months later, we would still be doing pandemic planning from a COVID response. And then of course, Ebola showed up in 2014 along with MERS. And while we did not really have much of an effect from the MERS COVID response, certainly from an Ebola perspective, we were very involved in planning along with the health departments as well as other health systems across the state, along with state and federal partners, and what would that Ebola response look like, and becoming part of the state pandemic or the state pathogen response network. So that was also very interesting in that hypothetical planning perspective, but also very critical to setting us up for success in the COVID planning. And I would think that I believe that any of the organizations that you might talk to that are involved in this current COVID response would say the same thing, that all of those instances historically that they have had to be involved with planning have really set them up for success going into this COVID-19 response. So just another little bit of a background from a response perspective, and specifically not only just healthcare, but from an emergency management public sector response. Critical element of the response planning and implementation is to have a solid command center structure. And so you will find that most healthcare organizations use what's called a hospital incident command structure. It's been developed and designed off from the fire scope, which is the incident command structure that fire departments use on every single call that they go out on, and is also reflective of what the public sector or the emergency management portions of the response also use. And so what's key about this structure is that during a response like this, if it doesn't matter if you're in healthcare or if you're in the emergency management sector or if you're in public health, from a response perspective is critical as we go into not only just a short response from a fire response or a mass casualty response, but definitely is critical as you go into a lengthy response such as COVID-19. And this is a structure that we have utilized within our hospitals for years. We've modified it to fit within the COVID-19 response, but we've also replicated it in various venues that we've established to be able to help support. So for example, I'm sure that most of you have heard about the West Michigan Vaccine Clinic down at DeVos Place, that collaboration between the health department, Mercy Health St. Mary's, and Spectrum Health. We also have a command structure down at that location. So again, it's making sure that all of these responders, all of these parties that are responding and are integral to the pandemic response are following that same sort of organizational structure, so that we know who is making the final decision, who is in charge of sharing media, making sure that we are understanding who our peers are and who we need to connect with as we go further into the conversation or into decision making. So now I want to talk a little bit about, I'm going to go into a little bit about the differences from a hospital perspective and then into health systems perspective, as well as into a health department perspective. And I want to touch on just a couple of things across all three of those sectors, and then really kind of point out where there may be some competing priorities, but then really understanding again by the end of the conversation the criticality of that interprofessional dynamic and that interprofessional collaboration between the disciplines that are involved in this current response. So certainly, as you look at healthcare, the landscape has changed dramatically over the last several years. There's definitely not as many independent hospitals as there were, 5 or 10 years ago. There certainly are larger systems than what there were maybe 5 or 10 years ago as well. And so as you look at that independent healthcare organization, that independent hospital, some of the things as they go into this COVID-19 pandemic response, that they're going to want to think about. And if they don't right away up front, as the pandemic has evolved, they certainly would be thinking about some of these topics from a sustainability perspective. So as you enter into that response, and this would be the same for all three of these disciplines that we're going to talk about, you're not necessarily thinking about that long-term sustainability, because truly at the beginning of all of this, I don't believe that any of us thought that we would still be here 14 months later having this conversation. But really looking at, how am I going to be able to maintain my patient care, ensuring that they have family members available when they need to have family members available to get the information that they need to make good, solid decisions. How am I going to sustain my business? How am I going to ensure that I have a revenue base to be able to care for our patients in the future? And this is specifically important for some of those smaller hospitals that are out in the rural areas, that is the only location of healthcare for some of those very rural communities. And so how can those smaller critical access hospitals make sure that they have all of a solid plan from a financial perspective to be able to maintain their financial base, make sure that they're caring for their patients, making sure that they're able to sustain their business through a COVID pandemic, and ensure that their staff and their patients are safe. Excuse me. Really looking at that resource management. Do they have the staff to be able to care for COVID patients? What do they need to do if they can't care for COVID patients? Where do they go? And then again, that's pulling from their financial base, from their patient population that they would normally be seeing. Do they have the appropriate PPE? And if they don't, and they're not part of a larger supply chain, how are they going to get it? Where are the resources that they're going to be able to find the equipment and the supplies that they're going to need for an appropriate and a safe pandemic response? Really looking at some of those competing priorities. For the first several months, everything goes on hold as we're working through this pandemic. But at some point, you need to get back at least a portion of your business back to business as normal, right? I mean, how we have IT infrastructures that need to have upgrades, and are we going to put those on hold, or are we going to move forward with those? And then if we move forward with them, how do they impact the COVID response? That's pulling resources away from a COVID response that might need to be shifted, looking at strategic priorities within your organization. And how does that fit within that same within that same COVID response? And then really looking at that psychosocial impact for that healthcare organization. And part of that goes back to that resource management and that sustainability, and being able to ensure that you're caring for not only your patients and their families, but you're caring for your team members as well, ensuring that they have the right support, that they're feeling supported by the organization, and that they understand that they have all of the resources necessary to be able to care for patients appropriately and safely. And some of these are actually going to be, again, competing with some of the larger health systems, right? So as we look at healthcare systems, then in some of these same challenges that they might have, while some of them are the same, there certainly are advantages from a health system perspective, from a resource management, right? I mean, they have a larger supply chain. They have a warehouse that they're going to be able to pull supplies from. And how does that compete then with some of those smaller healthcare organizations, and our resources being distributed appropriately across all of the healthcare organizations based on patient volumes that they're seeing, the number of organizations that they have within their business? And so does a healthcare system negatively impact or compete with some of those resources that are available for a COVID response, and compete with those smaller healthcare organizations? And how then does that affect both of them, right? So looking at system sustainability from a healthcare system perspective certainly might be a little bit easier conversation. You could, if you've got multiple hospitals, you can kind of shift patient volumes around to make sure that all of your healthcare organizations are healthy from a financial perspective. But again, if you have multiple hospitals, you're impacted that much more, right? So where is that balance in maintaining that financial stability, maintaining that resource management? Are you able to um, compete against some of the other locations for PPE better than a smaller hospital could do? Are you able to leverage relationships that you might have with manufacturers to be able to even manufacture PPE? We heard through the whole COVID pandemic about several different organizations stepping up to say, you know what, the Ford company, I can make masks. We'll just transition everything from cars to making masks or making ventilators or whatever the case might be. And how do those relationships vary from a response perspective with all of these different disciplines that we're going to be talking about today? And does that make a difference? Looking at system policy management and making sure that across an entire healthcare system, that change management is so much more complex than when you're talking about one healthcare, one hospital entity, or one EMS agency, or one long-term care facility. When you're a healthcare system, that change management is extremely complex, and making sure that every single one of the organizations is following policy, and when that policy changes, that those changes go out and everybody has been able to implement them. And I can tell you from this COVID response, we have had changes. When we first started out in March, I believe that we were changing decisions about every 72 to 96 hours based on the information that we were receiving from both the local health departments, the state health departments, and the federal government, along with the CDC and other agencies, of course. But managing those modifications to your policy and to your process, and getting those consistently implemented across your healthcare system so that everybody was functioning on the same platform, and ensuring that they were giving all of the same care. So definitely competing priorities from within a healthcare system are going to be similar to a small hospital or a local hospital. Really looking at that strategic list of priorities. And just for an example, we went over a list of projects the other day with our executive team that initially were associated with a COVID response, but now that things are dying down just a little bit, and our numbers are in a better place than our COVID admissions are in a better place than what they were before. Some of those priorities that we had on the list that were very COVID focused are no longer COVID focused. And for an example, some of our surge locations internally, we are not surging right now internally because our COVID numbers have decreased significantly. And so an internal surge location right now, if it's involving a significant number of technology resources, might not be on that COVID priority list. And so we've gone from a list of about 15 different projects that were all related to COVID about 3 weeks ago, down to a key 4 that really need to be prioritized. And that's one of those things that's important to keep in mind as not only a healthcare system, but all of these disciplines, again, that we'll talk about. What are those strategic priorities, and how is that COVID response impacting those strategic priorities? And then how do you weigh those, right? And 3 weeks ago certainly looked different than what it does today. And none of us have a crystal ball, of course, but we anticipate that maybe there will be another little bump coming up related to some of the variants that are around in the communities. But we're certainly hoping that the vaccine efforts are going to help mitigate some of that surge that we might see in the next couple of weeks. And so again, how does that impact all of those strategic decisions from that organizational perspective? So a lot of these, again, like we were talking about, are going to be competing priorities from one organization to the other. But certainly, as we continue on, you'll see that there's going to be a fair amount of collaboration as well. and the health departments. And as I was thinking about this this time that we have together, and thinking about how I was going to present this, I wanted to integrate some of the great relationships that I've been part of through all of the emergency preparedness efforts that that we've had over the last several years. And certainly health departments are very strong advocates and very strong collaborators with all of us. For those of you that don't know, the state has divided itself up into 8 different planning regions, and that's related to not only Michigan State Police, but also related to healthcare preparedness. And so we all on the west side right here are part of Region 6. It goes from Ludington over to Mount Pleasant, down to Ionia, back out to the Lakeshore. It's those 13 counties that are in that geographical location. And we work with all of the response partners. So anybody related to any sort of healthcare emergency response is part of that coalition. And health departments are a big piece of that. And so as I talk about this, I want to make sure that while we all have competing priorities, I want to make sure that this by no means is to indicate that we don't plan together and we don't collaborate together, because that definitely is not true. So as we look at the health departments, one of the challenging pieces is that they are jurisdictionally run. And so while we have the state, Michigan Department of Health and Human Services, where that state health department fits into, every local health department is part of its local jurisdiction. And so that means that the state can give guidance, but every jurisdiction can theoretically implement that guidance the way that they feel they need to based on their patient population or their community population, and how they can best support their community, which makes it a little bit challenging when you've got, thinking back again to the health systems that might have hospitals in several different health department jurisdictions, and how do we manage that response? And it's difficult for even the health departments because they collaborate together. And if they're implementing something a little bit differently than the next county is, makes it again a little bit more difficult to work through some of those roadblocks and some of those barriers. And not that they're showstoppers by any means, because of the relationships that we've built, but definitely takes a little bit longer than maybe what it would on any given day. So looking at a health department from a jurisdictional perspective and resource management, again, their resources are coming in from a different direction than potentially what the healthcare systems are and what the hospital resources are coming in. So that can balance out very nicely with, not a competing, they're not going to compete necessarily with healthcare. Some of them, certainly they're going to be getting some resources from the state and from the feds to be able to help support their efforts. Definitely, people are going to look at the health department from a pandemic perspective that is traditionally thought of as a health department response, and it's their responsibility to help drive that response. To be honest, there's been a lot of conversation over the past 10 or 15 years, even at the federal level, on the lack of support, the lack of federal support around the health department structure and the ability to be able to manage effectively a large pandemic such as the COVID-19 pandemic. And so it's very well known that the health department resources internally, from a personnel perspective, are not supported to be able to help in managing such a large incident such as a COVID-19 response. And so they've had to rely on other healthcare partners and other planning partners to be able to help support that health department effort around the COVID-19. And so again, their patient base is actually the population base of that county. And so as you look at that 13 county area that I was just describing, definitely looking at social vulnerability indexes and various diversity indexes the picture within that 13 county area is significantly different than maybe the picture that you might see on the east side of the state. And it varies even from county to county in our Region 6 planning area, as some of the most the counties that are definitely needing the most support when it comes to healthcare are some of those counties that have the least amount of healthcare. And so how does the health department support those counties, and how does the health department partner with some of their other planning partners to be able to help support some of the patients in those very poor populations in counties and very diverse, ethnically diverse populations, as well as certainly the income level within those areas as well. Population based also is looking at, and something that's hit home definitely during the COVID-19 pandemic has been the homeless population. And how does that population get managed? And is that a responsibility of the health department, or is that a responsibility of the healthcare systems or the hospitals that are seeing those patient populations? And how do we manage that? Looking at community health and what is the health of the communities in which those health departments live. And then again, some of those competing priorities. And I will use the homeless patient population as an example for that. Probably about maybe 6 or 8 months ago, we had several conversations with our local health department around the homeless population. And I think that all of us were on the same page, right? We all knew that we need to take care of this patient population. They are very vulnerable. They're mobile. And that's not something that plays well with a pandemic, especially a respiratory pandemic. Excuse me, they live in cohorts, again, which is not going to be a positive for the COVID pandemic in trying to control the spread of that disease. And the follow through from a healthcare perspective is not high in that patient population. And so if a homeless person would come into one of the healthcare organizations to seek treatment because they were not feeling well, was a COVID positive patient, but didn't require hospitalization, we couldn't send them back to whatever shelter they were living in, because there would be huge potential to infect the rest of the shelter, right? We needed to be able to isolate them. And so while this was, the health departments were like, we understand this, but somehow we need to figure this out. From a healthcare perspective, as we're looking at surging and really needing that inpatient bed for some of the other more critically ill patients, and then we have this patient that didn't really physically need to be there, but yet was in one of those inpatient beds that we could have used for a more critically ill patient. It was that dichotomy of how do we work through that whole thing with all of our planning partners. And fortunately, again, we have worked with the Kent County Health Department for a very long time around healthcare planning, had a great relationship. And Carla Black, who is a colleague of mine over at the Kent County Health Department, called me up and said, you know what, we've just got to figure this out. I said, great, let's have a conversation. I got our social workers together with Carla and her team, and we worked out a process for this patient population to be able to go back to a pre-identified shelter who would then isolate this patient population. They isolated them within a homeless shelter, ensuring that we educated the staff there. They were open 24/7. We had contact for them to call if they had any questions or needed to have any issues raised or evaluated. And it kept the patient population both internally within that shelter and also the rest of the patient population safe and healthy. Oh, excuse me. One more drink here. So I think that, again, as we were talking about the competing priorities, and certainly from an organizational perspective, there was a little competition from a priority perspective around that patient population with the health department and with some of the healthcare organizations within the county. I think that was a great example of this slide as we kind of pull everything back together again here. And then I can leave some time for questions if there are any. Definitely through any response like this, there are going to be some competing priorities for each individual organization or each individual discipline based on what their business is, right? And especially if it's a lengthy response, such as the COVID pandemic has been. If it's a short-term response, the impact is definitely not as important as or as critical as what it is from a long-term perspective. And so as we looked at some of the conversation that we've had around financial management, making sure that the organizations are financially stable to be able to go and care for all of the patient population through this lengthy response, making sure that we look at strategic priorities in all disciplines, across all disciplines, and how do those intersect. As we look at the competing priorities, I think that we can also confirm that those are also the priorities that are driving all of the collaboration between the disciplines related to this particular response. And resource management, certainly, as we look at resource management across healthcare, across the hospitals and across the region, certainly the driver of what those resources are going to be is going to be coming through the CDC and through the health departments and what is the appropriate PPE available. We look to our health departments as the experts from a public health perspective when it comes to a pandemic such as this. They're the experts when it comes to this. Certainly, as we look to the experts and we talk about the resource management and the resource inventory and where are we going to be able to get supplies, we partner with all of those disciplines to be able to ensure that not only an individual organization is safe, but also that our communities are safe. So I believe that through the collaboration with the health departments, the health systems, and the hospitals, are also really focusing not only independently on themselves, but also have a much broader perspective from a community base. And what does that mean through the pandemic? How can we partner better with our health departments? And I think as the vaccine has been rolling out, or I should say the lack of vaccine, but as the vaccine has been rolled out, that it's another great example of how we can come together and ensure that we are covering our communities, blanketing our communities with vaccine according to those the tiering structure that the state has implemented through their plan. So as we're focusing on initially healthcare workers and focusing on our employees from a hospital and a healthcare system perspective, and we move into those next phases that are traditionally thought about as a responsibility to the health department. Again, going back to that conversation we just had with the lack of resources and the lack of infrastructure that the health departments have, how can we as health systems and hospitals partner with our health departments to ensure that our communities are safe and healthy? Because that is the ultimate goal, right? So despite the fact that we might have some competing priorities on a day-to-day basis through this pandemic based on discipline, the outcome is that we all have the same goals in mind, and that is the safety and the health and wellness of our communities. And so how can we partner together? So through this, we've been able to help support vaccinations for specific school groups. And again, counties have done this differently depending on what county you're in. And so the best example that I have is Kent County, where all of the health systems within Kent County have divided up all of the school districts within Kent County and have taken on the responsibility to vaccinate all of the workers within those school districts, as well as law enforcement and first responders and some of that leftover 1A healthcare group. We're now focusing on how can we best partner with health departments in all areas in vaccinating the Black and Brown community that are very much affected by this disease. And how can we partner with the health departments in vaccinating those that are 65 and 75 years of age and older? And how can we get them to a clinic, or how do we think creatively, break down the barriers that we've historically had, and partner with the health departments to get to those patient populations when they're not able to drive to a clinic or walk into a clinic? We've had great creativity in working with the Ottawa County Health Department and developing almost like SWAT teams, like you could call it, of teams that would go into long-term care facilities or would go into assisted living locations and do a mass vaccination at a particular location. And so just kind of as I wrap things up here towards the end, I really want to focus on the benefits of past relationships that we have developed through all of the planning efforts that have occurred over the last several years. I mean, I've been involved in healthcare emergency preparedness for probably 20 years. And the relationships are critical to the implementation of processes and the collaboration and the success of a response such as this. And certainly we could not have done it without the relationships that we've been able to establish. But I think that it also shows that when there's an incident such as this COVID pandemic that's as impactful to all aspects of a patient population, and whether that's their financial well-being, whether that's their psychosocial, emotional well-being, whether that's their physical well-being, as it comes to looking at the patient as a whole and the community as a whole, I believe that it is critical for all of these disciplines to come together to be able to function collaboratively, to be able to bring the best level of care and support into our communities and caring for our communities, which is what that ultimate goal is all about from a pandemic response, or even from an emergency response of any sort. And so despite the fact that we've got competing priorities, that ultimate goal of being there for our communities, making sure that our communities are safe and healthy, the collaboration is really what takes over and helps us work through some of those competing priorities that we have. And definitely the collaboration is what wins out in the end and has made all of our communities successful as we've worked through this COVID pandemic. And I apologize for not going forward on my slides. I got too busy chatting. So that is all that I have to share. And so I am open to conversation and answering further questions.
Thank you, Dr. Bolson. And if you do have questions at all, please feel free to use the Q&A feature at the bottom of your screen. I will start with the first question, which is, would love to hear you reflect on how organizations have learned to add a step in their decision-making process to include an ethical reflection on the decision at hand. So maybe talk about that step in ethical reflection related to decisions.
Yeah, absolutely. And that's a great question. And so through all of this, and again, as I kind of reflect on the history of the planning process, in 2009, when we were talking about the H1N1 response, there was a huge ethical component to that. And so taking lessons learned from that incident into the current pandemic, we have for those of you that don't know, there's a state ethical committee that actually has developed state ethical guidelines available for anybody to view and for healthcare organizations to use as a guidance for their ethics process. We've been fortunate enough to be able to have the resources within our health system and other health systems as well to pull together either an ethics committee or a scarce resource allocation committee, which is really kind of the structure that the state has outlined as well, to have some of those conversations. And it is from as simple as, how do we allocate beds? How do we allocate ventilators and medication supplies, to the current challenge of how do we ethically distribute vaccines? And what is that percentage of vaccine that we get? Because we know we certainly don't have enough of 65 and older. What is the percentage of Black and Brown community that we want to touch? What's that percentage of allocation that's going to go to the healthcare, the first responders, or to the teachers? And so we've been fortunate enough to be able to actually just build that right into our conversation. And our ethicist has been able to participate in a lot of the conversation and inventory capacity management. So as we look at distribution of resources, our on-staff ethicist has been able to be part of those conversations to help us weigh some of those. Is it about healthcare as an infrastructure, or is it about me individually as a healthcare worker, or me as an individual a healthcare support for a family member that lives at home? So do I identify with healthcare workers? Is that really part of the whole healthcare infrastructure? Lots of really, really great conversations around ethics, helping us to refocus what really is the foundation of, specifically now, the vaccine administration and the vaccine distribution. And so when we have vaccine available, we go through all of those steps, coming down to that very last foundational principle of, we will waste no vaccine. And it is our job to get as much vaccine into arms as we possibly can. So certainly it's important for other healthcare organizations or other entities that might be responding and having conversation around scarce resource allocation to be able to tap into somebody who is a specialist with from the ethics community to be able to help guide some of those decisions and really help us look at things from a different perspective. It's been great. It's been enlightening, and I've really enjoyed working through that process. On mute.
Thanks. We had another question from an attendee. If you might be able to quickly or briefly show the health department slide that you had.
Oh yeah, sorry. Let me see if I can. Get back there. This is Julie Technology Challenges. So here we go. Backwards. There we go. So it really was a lot of the same items that I was hitting from a perspective from all of those disciplines. Just really wanted to talk about how it might vary from hospitals to healthcare systems to health departments, even though they're the same, topics of conversation, and then how that might interplay with some of those other disciplines that they interact with on a daily basis.
Thank you. Another question is, how do we engage communities of color effectively in partnership with our county health departments?
Yeah, so that's a great conversation. I know that our health departments have really been focusing on various zip code areas that have higher populations of people with color. And so they're focusing right now from a vaccine perspective, spot clinics within those areas so that we can really focus on those communities in and of themselves We know that there's some hesitancy around vaccine administration within that particular community, the communities of color. And so some of the tactics, if you will, that we're using is really to focus on some of the leaders within those communities that we know are influencers for that population, and helping them understand that the vaccine is safe, and the pandemic response, the things that are important, the tactics that are important from a pandemic response, wearing a mask, social distancing, are all critical to managing this disease and helping those leaders or those influencers within those communities to share that information with their populations. One of the other things that we're doing along with the health department is targeted education. So again, we're finding a location that is comfortable for that patient population to go into, to be able to receive that education and answer questions in the moment, as opposed to having them go outside of the comfort of their community into another location to be able to either get a vaccine or get that education. Hoping that through that education, through some of the influencers, we're using pastors, we're using, grandparents, we're using anybody that might be able to influence some of that patient population into understanding the vaccine and the benefit of the vaccine and the benefit of the response, using all of those types of influencer people in that community to help share that information, but doing it locally. So we are targeting specific zip codes of those patient populations to be able to bring that information in and to be able to bring the vaccine in, as opposed to asking them to come out into a larger population.
Thank you. Well, that appears to be all the questions that our audience had. And so on behalf of the MyPERC organization and our Grand Valley State University Interprofessional Education Office, I wanted to thank Dr. Bolson again for being our speaker at our February Lunch and Learn and sharing a bit more about how hospitals and health systems and health departments and how those priorities align and sometimes compete. And in particular, how those relationships that were already developed allowed for successful collaboration and relationships during this challenging time. So we thank you again, Dr. Bolson. I also wanted to share our March Lunch and Learn will be on Wednesday, March 24th, and that's going to be on community mental health and COVID with Dr. Eric Atchis from the Pine Rest Christian Mental Health Services, and registration for that's available on the MyPERC Lunch and Learn page. So if there's any additional questions for Dr. Bolson, I know she had her contact information on the last page. You can also feel free to contact me and I can forward those on to Dr. Bolson. I wanted to just, there was one more comment that was put in right before we end here from Mike Fortman at the Kent County data scientist that said he's a data scientist for Kent County and had been very involved with the demographic analysis, zip codes, vaccine allocation and distribution, and that you were spot on. So thank you from Mike at Kent County. Perfect. So again, thank you very much. And we hope that you have a great rest of the day, and a recording for this will also be available on our MyPERC Lunch and Learn website. So thank you and enjoy the rest of your day.
Thank you so much for the opportunity.